Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 40 of the OBGYN podcast. Today, we're going to continue and finish up our discussion on aneuploidy, and to do that, we're going to talk about amniocentesis and chorionic villus sampling, cell-free DNA, and then we're going to talk about some cost-based analysis and try to figure out what the best approach is. So, without further ado, let's get started with episode 40, Aneuploidy, Part 2. In the first part, we discussed how we discovered serum analytes and the relationship to aneuploidy. And over the years, as we discovered more and more of these analytes, we increased the sensitivity while keeping the false positive rate steady, around 3 to 5%. Now, the gold standard during this time was amniocentesis, but it is an invasive test and carries a small chance of miscarriage. Well, what if we had a test that gave us the same sensitivity and specificity, but without the risk? I'm talking about cell-free DNA, or as it's been branded, non-invasive perinatal screening, or non-invasive perinatal testing. We are going to spend a good portion of our time today talking about that, but before we get there, I do want to spend a few minutes to talk about amniocentesis and chorionic villus sampling. As I covered in a previous episode, amniocentesis started in the 1930s as a way to determine placental location. By the 1950s, it was being used in the management of Rh isoimmunization. A decade later, we get the first description of karyotype from cells obtained during amniocentesis, and as we discussed in the last aneuploidy episode, the real breakthrough came when we started to be able to culture these cells, which made it much easier to perform a karyotype. This was first reported in 1960, and by the end of that decade, amniocentesis and karyotype was being used to determine sex-linked diseases and the gender of fetus and women with a history of X-linked disease. And by 1968, it was being used in the diagnosis of Down syndrome. Let's review how an amnio is performed quickly. A genetic amnio is traditionally performed between 16 and 19 weeks, although it can be performed as early as 11 weeks and, of course, any time up to delivery. In modern obstetrics, an ultrasound is performed to assess the location of the placenta, the position of the fetus, and any pockets of umbilical cord. Ideally, the needle will not be inserted through the placenta and will be placed away from the chest and head of the fetus. Inserting it near the arms or legs is generally considered to be okay, and I think obviously we all know to avoid the cord. After the insertion point has been identified, the abdomen is cleaned with betadine and a hollow needle with a stylet is introduced under ultrasound guidance. Once the amniotic cavity has been entered, the stylet is removed and a syringe is attached to the hollow needle, and the amniotic fluid is removed. This is usually done in 2 steps. The first is to remove a couple of cc's, which gets rid of any maternal blood that may be in the needle from the insertion, and then a second syringe is attached and the sample is taken for testing. Now, up until the 90s, the only test available was a traditional karyotype, and due to the fact that the cells need to be cultured, there is a hard limit on how fast that can turn around, and that's about 10 to 15 days. In the late 80s, fluorescent in situ hybridization was invented, in which antibodies against stable portions of the human chromosomes are tagged with fluorescent material. After the antibodies bind to the chromosomes, the fluorescent pattern can be used to determine chromosome number. This test trades a little sensitivity, 97% versus 100%, for a much faster turnaround time, roughly 24 to 48 hours. And today, most labs use these 2 tests together. They give a preliminary result with FISH, and then a final result with the karyotype. Other techniques like microarrays and qF-PCR seem to perform well and probably will become important in the future, but right now they remain prohibitively expensive. Chorionic villus sampling is a different technique that can be used for obtaining fetal cells for karyotype. It was actually developed around the same time as amniocentesis, but took much longer to mature into a viable clinical solution. In this technique, the goal is to obtain placental cells as opposed to extracting fetal cells from the amniotic fluid. To perform the CVS, a needle is placed into the placenta either transcervically or transabdominally, and then cells are either aspirated or extracted with a biopsy forceps. Before the advent of modern ultrasound, this technique was very difficult because not only could we not always tell what the placenta was, we also couldn't visualize our needle to make sure that we were getting placental and not maternal cells. But as ultrasound technology matured, so did our technique for CVS, and today it is much safer than it was. The main advantage of CVS is that it can be done as early as the placenta starts to form, at 6 weeks, although most people choose to wait until 9 to 11 weeks, which still is several weeks earlier than the genetic amnio, and gives a woman earlier and therefore safer access to termination if that's what she desires. So as we said, the sensitivity and specificity are exceptional for amnio and CVS, but they do come with a price, a risk of miscarriage. So, who should we offer it to? Should we use it only for women who are at elevated risk? And if so, how do we define that? Well, let's take a look at those complication rates for amnio and CVS so that we can better make a decision about who we should offer it to. Now, if there were no risks, the test is accurate and not costly, then we should offer it to everyone. So what are the risks? Well, from the beginning, we knew that there would be some risks involved because even for the third trimester amnios, which have been done for much longer than the genetic amnios, there was about a 1% risk of fetal loss. However, because genetic amnios are performed in the second trimester instead of the third, the fluid-to-fetus ratio is different, and the amount of placenta relative to the size of the uterus is also different. These two factors made it much more likely that either placenta or the fetus would be in the path of the needle. Compounding this is that high-quality ultrasound wouldn't be available until much later, and so most providers were blindly inserting the needle without even the knowledge of where the baby or placenta was. Now, one of the earliest studies to look at the safety of these mid-trimester amnios was from Paul Manganiello at the Medical College of Georgia and was published in AJOG in 1979. A year earlier, actually, the NICHD had published a report from their amniotic fluid registry of 1,040 women and found that there was no difference in rate of pregnancy loss with amniocentesis. However, this was a voluntary registry, and so many providers felt that providers just weren't reporting their complications. This is why Dr. Manganiello's paper was so important. He published his experience with 252 women who underwent genetic amniocentesis over an 8.5-year period. He found that during that time there were 11 fetal losses, of which only 2 could be directly attributable to the amnio, and an additional 5 that were deemed to be of unknown etiology and could possibly be related. In addition, they had 1 case of Rh sensitization, which they thought could have been caused by fetal-maternal blood mixing from the amniocentesis. This complication rate of about 1% was also seen in a number of other papers from that time, and has become the generally agreed upon number for the risk of pregnancy loss with genetic amniocentesis. However, there is a difficulty in interpreting any of these studies. The real risk of amniocentesis is hard to determine because most of these papers did not have an adequate control population to account for the background rate of pregnancy loss, which means that they may have been overestimating what the fetal loss rate was from amniocentesis. A meta-analysis from the Green Journal in 2007 highlighted this issue, and they found that only 5 studies on the risk of amniocentesis had adequate controls. When using the best studies, the meta-analysis showed that the fetal loss rate increased by 0.6% from baseline, which is slightly lower than the 1% from the earlier studies, and may be, in fact, due to that lack of control. Now, these same control issues are present in the CVS studies, but the overall rate seems to be slightly higher than for the amnios, and may represent either a real increase from the more invasive nature of the procedure, or due to the fact that they are performed earlier in gestation when the background rate of miscarriage is higher. In either case, the rate seems to be relatively steady over the last 20 years, so about 0.6 to 1%. So let's go back to our original question. Who should we recommend an amnio to? Well, as we discussed last time, age 35 and its roughly 1 in 200 risk of having a pregnancy affected by aneuploidy has historically and somewhat arbitrarily been used as a cutoff. If we offer an amniocentesis to every woman over 35, then we'll be causing about 2 miscarriages to diagnose every 1 baby with aneuploidy. Well, when you say it that way, it doesn't sound so great. Well, of course, as the prevalence increases, that calculus changes, but where do we draw the line? Is it at age 38, where we have 1 miscarriage to 1 diagnosis, or at age 40, where we have 1 miscarriage for 2 diagnoses? Now, as per usual in this podcast, I don't have the answer for you, but I think it's a question that we need to ask ourselves. So now that we've talked about the risks and benefits of amniocentesis and CVS, we can see why we have spent so much time trying to find ways to risk stratify women. What if we had a non-invasive way of obtaining a fetal karyotype? If we get the same answer with none of the risk, it would be the holy grail of aneuploidy testing. Now, Cellfree DNA may be that, but as we'll see, we're going to run into some issues with prevalence and predictive value. To talk about Cellfree DNA, we need to start in 1969. In that year, Walkanowska discovered the presence of a XY metaphase in a pregnant woman carrying a male child. By the late 70s, people were using flow cytometry to try and sort fetal lymphocytes from maternal blood. But it wasn't until the late 80s, in the advent of PCR, that it was definitively proven that fetal cells do in fact exist in maternal blood. Well, the next question that these researchers had is which fetal cells are making their way into maternal circulation. The natural candidate would be the trophoblastic cells from the invading placenta. Well, in 1984, Quavine et al. Published a paper in which they claimed to have used flow cytometry to select for trophoblastic cells using monoclonal antibodies against an antigen specific to those cells. 4 years later, the same group determined that the cells they had selected for were actually maternal lymphocytes that had absorbed the trophoblastic antigen. Now, this would lead other researchers down a blind alley, but importantly, is one of the first clues that maybe parts of fetal cells were actually circulating in the maternal blood. Well, like I said, other groups did focus on lymphocytes or granulocytes because they could sort them based on paternal HLA types not present in the pregnant woman. The problem with this technique was that there was a limited number of these circulating in the maternal blood, and that the researchers had to know the paternal HLA type in order to do the test. Well, to overcome these challenges, other groups focused on the fetal nucleated red blood cells. This has some major advantages as compared to lymphocytes. First is that they were much more prevalent in fetal circulation, and therefore appear in larger numbers in maternal blood. And second is that because adult RBCs have no nucleus, any nucleated cells seen in the maternal blood had to be of fetal origin. Now, once these cells were obtained, efficient analysis could be done to detect aneuploidy. Well, as you can probably infer from all of that, this was a very complex and expensive process, and basically ended up getting to the same place as doing an amnio. It certainly had a low risk of complication, but also, in fact, had a higher false negative rate. Now, while groups were continuing to refine their fetal cell purification process, other groups were going back to the idea that cell-free material may be floating around in the maternal blood supply. This idea initially started with cancer research done in the mid-90s that showed that tumor DNA could be found free-floating in patients' blood. These techniques were then applied to fetal DNA by a group led by Redmond from England. They took blood from 43 pregnant women with gestational ages ranging from 12 to 40 weeks and attempted to purify Y chromosome DNA from plasma, serum, and nucleated RBCs. They were able to detect Y chromosome material in 24 of the 30 women carrying a male fetus, and no Y material was detected in any of the 13 female fetuses. Lastly, in 10 non-pregnant control women, they also did not detect any Y material. Now, this was the first shot in the race to use cell-free DNA as a prenatal diagnostic test. At first, this new tool was targeted at sex and Rh status of the fetus, but then, in 1999 and 2000, Lowe and another group published work that showed that quantitative PCR could be used to determine the amount of each chromosome-specific DNA present in maternal blood. In their two studies, they found that on average, women with trisomy had higher amounts of DNA from that chromosome. At this early stage, it still wasn't great, but it was enough to fuel the fire. Several of these groups explored different methods for isolating fetal DNA, while others looked at the overall ratios of DNA from different chromosomes in mixed maternal fetal DNA samples. Let's start with the second method. In that technique, PCR primers are used against a known portion of the target chromosome, and the number of copies of that DNA snippet are counted. This is then compared against a reference number for that chromosome, and if the study number is higher, then aneuploidy likely exists. This technique works well for autosomal chromosomes like 13, 18, and 21, but not so well for sex chromosomes because women will lose an X chromosome in some portion of their own cells, and the number of these X-deficient cells increases as they age. Overall, it is a great technique and is still used in many of the commercially available tests on the market. Now, the other technique uses SNPs, or single nucleotide polymorphisms, to only amplify fetal DNA. The actual process is far too complex for me to understand completely, let alone explain it to all of you, so I'll just say that it is more involved than the earlier technique, does not require a reference value, is much more computationally intense, and needs a higher volume of DNA to return a result. Now, on that note, there are two factors that seem to affect the amount of fetal DNA circulating in the maternal serum. Those are maternal obesity and aneuploidy. The effect of obesity is thought to be due to increased cell-free DNA from maternal adipocytes, and for unknown reasons, trisomy 13 and 18 in particular are associated with decreased fetal DNA being present in maternal serum. Therefore, many recommend amnio or CVS to women when their non-invasive prenatal screening comes back with no result. Okay, so now that I've explained how we got to NIPS, let me tell you why everyone was and is excited about it. It's very good. For the sake of this podcast, I'm going to work with numbers from the Maternity 21 test. Other tests like Panorama, Verify, and Harmony are a little different, but they're close enough for this discussion. If you want a graphical representation of what I'm talking about, then follow the link in the show notes to the UNC Chapel Hill aneuploidy calculator. So let's get into those numbers. The Maternity 21 cell-free DNA test is 99.1% sensitive and 99.9% specific for detecting trisomy 21. Due to the issues with fetal DNA amounts, it is slightly worse for 18 and 13, but it's still pretty good. For 18, it is 99.9% and 99.6%, and for 13, it is 91.7% and 99.7%. This is great, but it is not all good news. The main downside to the test, and the issue that we're going to spend the rest of our time talking about today, is that due to its fundamental nature as a screening test, its positive and negative predictive value are determined by the prevalence of the disease in the population, which means that as the prevalence decreases with decreasing maternal age, the test performs worse and worse. The major factors that affect this are maternal age, obviously, but also gestational age. Because pregnancies affected by trisomy are more likely to end in miscarriage, the incidence of trisomy actually decreases as gestational age increases due to pregnancy wastage. Again, for today's discussion, I'm going to talk about tests that are done at 10 weeks. And again, you can go play with the numbers yourself using that calculator and move the gestational age around. So let's get into some numbers to highlight this. For a 35-year-old woman with Down syndrome, risk of 1 in 187, the negative predictive value is greater than 99%. So if it is negative, it is almost assuredly negative. The positive predictive value is 84%, which gives us a false positive rate of 16%. Not terrible, considering that many of these women were opting for amnios or CVSs anyway, and so overall, this would serve to decrease the number of invasive tests being performed without missing nearly any of the cases of Downs. Now let's look at those same numbers for a 20-year-old. A 20-year-old woman has a 1 in 804 risk of having a pregnancy affected by Downs. The negative predictive value stays the same, which is great, but the positive predictive value falls to 55%, which means that roughly half of the positives will end up being wrong. For a 25-year-old, the positive predictive value is only slightly better at 58%, and for a 30-year-old, it's 68%. As you can see, the further we slide down the maternal age scale, the higher our false positive rate. Now, for the early years of cell-free DNA, it was only recommended for women 35 or older, and as we said, it performs well in that age group. However, recently, ACOG has recommended that it be offered to women of all ages, and here is where that false positive rate starts to rear its ugly head. What do we offer that 25-year-old with a positive result? We know that there's a roughly 40 to 50% chance that it's an erroneous result, but can we not offer them an amnio once we have it? And then, tying it back to our amnio discussion, how many complications are going to result from those amnios or CVSs? Again, I won't pretend to know what the right answer is, but it's a conversation we need to have amongst ourselves before we universally adopt NIPS in all women. Since we know the limitations of cell-free DNA and that its positive predictive value, like all screening tests, is dependent on the baseline incidence, is there anything we can do to improve its utility? Well, maybe there is. Maybe we can use the first trimester screening from the last episode to pre-screen women for trisomy risk, and then use the NIPS for women with a risk that's the same as a 35-year-old. Now, many places do just this, but it is controversial because now, in effect, we are using 2 screening tests, and this is going to delay definitive diagnosis, as each test does take a while to come back. The ultrascreen is usually done between 11 and 13 weeks. Therefore, it may not be until 12 to 14 weeks that we get a result. And then we're going to do NIPS, which takes about a week. And so we may not end up doing our amnio or CVS until 13 to 16 weeks. And then that result takes a week to come back. So now we're suddenly at 15 to 18 weeks by the time we get confirmation, at which point we are exactly where we were when we started doing second trimester screening back in the day, and we have spent a lot more money to get there. Now, this is a little confusing, so let's put some real numbers on it. Let's look at a Singaporean study that examined 3 different models for screening women with trisomy. They included over 10,000 women with singleton pregnancies that were screened for trisomy during their pregnancy. They looked at 3 models. The first was first trimester serum screening for everyone, with an amnio offered for women with a risk of greater than 1 in 250. The second was first trimester screening for everyone, and then if aneuploidy risk was less than 1 in 100, the woman would be offered a CVS or an amnio. If the risk was between 1 in 100 and 1 in 1,000, they would be offered NIPS, followed by amnio if positive. The third was NIPS for everyone, followed by amnio CVS for positive screens. In the study, the average age was 31.6, with 25% of the population being AMA. As noted, they all had first trimester serum screening, and 292, or 2.85%, were screen positive on that test. Almost 300 women had invasive testing based on those results, including 49 from the screen-negative women who had abnormal ultrasound findings. Overall, there were 54 cases of trisomy out of 10,000 pregnancies, including 3 in the screen-negative group, for a false negative rate of 0.03%. Then they used the published data on NIPS to determine what the cost and utility of NIPS would have been in that population. What they calculated was that using the first method, which was first trimester screening coupled with amnio, would result in 288 amnios, 6 missed cases of trisomy, and cost about $248 per woman. Using the third method, which was NIPS for all, it would result in 80 amnios, no missed cases, and a cost of $734 per woman. Using the middle method, which was first trimester screening, amnio for high risk, and NIPS for intermediate risk, would result in 180 amnios, 2 missed cases, and cost $296 per woman. So obviously there's a great reduction in the number of amnios performed by implementing NIPS, with the number of possible invasive tests falling from 288 to 80. However, there was also a substantial increase in cost from $248 to $734 per woman screened. The middle method seemed to be the sweet spot, with 1/3 fewer amnios, but also only a modest increase in price from $248 to $296 per woman. Now, a few caveats here. First, that this is almost purely a thought experiment, because NIPS was not actually used in the study, and so its performance is solely in the realm of theoretical, and does not take into account results that come back inconclusive. It also calculated the PPV and MPV for NIPS using the average age, and did not apply individual age effects. And because it did not apply individual age, it most likely overestimated its effects and underestimated its false positive rate. That being said, it does give us some real numbers to use as we frame our discussion. One last consideration is who in the population gets an amnio. In the first model, only women with an elevated risk, calculated by serum screening, age, or ultrasound findings, would get an amnio. In the NIPS for all model, even though there are less amnios overall, we now have young women with much lower risk who end up getting an amnio because of a false positive. I'm not sure how much that matters, but it does nag at me a little bit. Now, the last drawback to going all in on NIPS in lieu of combined first trimester screening is that NIPS does not detect sex aneuploidies or other non-21-18-13 trisomies, nor does it give some of the other early warning signs for things like preeclampsia. As technology advances, I imagine a future in which NIPS will be the only screening method needed for trisomy. But until then, the more I read, the more I feel like in women under age 35 that it is best implemented with serum trimester screening as opposed to in place of it. But to be honest, that's a judgment call. How many misdiagnoses are worth a complication from a CVS in a 25-year-old? I don't know, and that leads me to my last point today, and that is, how do we counsel women? Now, I have long held the belief that doctors exist to synthesize all the information and make a recommendation to our patients. The whole concept of informed consent always seemed to be absurd to me, as how can we expect non-professionals to ever truly be informed of all the risks and the benefits? Now, let me be clear. I am a firm advocate that we need to fully inform and counsel our patients, and that we should never be withholding information from them. But to expect that we are going to be able to spend 30 minutes with them and have them walk away with the knowledge that we spent a decade or more obtaining is just not reality. If I went to an accountant or a lawyer, I would expect that they would give me an overview of the topic, outline the general pros and cons of any strategy, and then expect them to make a recommendation to me. And that is exactly what I try to do for my patients. But when a choice comes down to a value judgment, like a very low percentage of misdiagnoses or a very low risk of miscarriage from invasive testing, how do I make a recommendation? I struggle with this one, and I guess this is the podcast where I give you all more questions than answers because I haven't figured it out for myself. After speaking with colleagues and residents, I do believe, however, that many of us professionals don't fully understand the inherent trade-offs being made, and this is actually what got me interested in this topic to begin with. And I hope that by reviewing how we got here over the last couple of episodes on aneuploidy, that you all can give this topic some critical thought, and hopefully it will help you inform your counseling in the future. Now with that, I'm going to bring aneuploidy to a close. I could probably spend another episode on this topic, but I do have other things that I want to get to. Which reminds me, I'm always looking for people to contribute, and yes, that means you. If you are inspired by this type of deep dive into a topic and have something that you want to give that same treatment to, then please reach out to me. My email is in the show notes and on the website at obgyn.fm, and if you think that there is no way you could possibly do this, well, I'll tell you I thought the same thing before episode 1, 2, 3, 4, and well, you get the idea. We'll have to start somewhere, and all the other voices that you've heard on this show came from someone like you reaching out and taking a chance. And with that, I'll say, thanks for listening.